age groups, neonatal conditions are the #1 cause of disability-adjusted life years, accounting for 7.2% of global dailies alone. This is explained by the high mortality rate in neonates, and a large number of long-term neurological impairment acquired during perinatal period. One of the main causes of this neonatal injury is related to preterm birth and intraventricular hemorrhage. I decided to focus on the onset of intraventricular hemorrhage and investigation of the antecedents in the hope that we can explore preventive measures and implement effective interventions in the future, targeting to reduce the occurrence of this devastating condition. My name is Zsuzsanna. I'm a first-year PhD student, and I'm also working at Semmelweis University, Department of Obstetrics and Gynecology, Korányi Perinatal Intensive Care Unit, as a senior neonatologist. My supervisors are Mikros Szabó and Arjen Topaz, and my scientific methodology supervisor is Vanda Máté. My vision is to implement new effective and safe neuroprotective methods at national and international level. My vision is to implement new effective and safe neuroprotective methods. My mission is to study and validate neuroprotective delivery room stabilization methods in preterm neonates. In the topic of neonatal neuroprotection, we will primarily focus on investigating the onset of intraventricular hemorrhage in preterm neonates. After a thorough analysis of literature, our next step is to perform clinical trial protocol and then conduct a clinical trial. As I mentioned before, my first project will focus on investigating the onset of intraventricular hemorrhage in preterm neonates. My fields of interest are the preterm neonates with intraventricular hemorrhage up to the gestational age of 32 weeks, or preterm births with birth weight up to 1,500 grams. In preterm infants, the risk of neurological impairment, including germinal matrix, intraventricular, intracerebral hemorrhage, increases proportionally to the degree of immaturity. IVH is a frequent complication of prematurity, with a pooled estimate of 34.3% among extremely preterm infants, and associated with increased mortality and long-term adverse neurodevelopmental outcome, such as motor skill development latency, cognitive impairment. We don't know the exact onset of intraventricular hemorrhage, but we do know that 80–90% of the cases occur within the first 3 days of life. That's why our aim is to describe the onset of intraventricular hemorrhage in this vulnerable population. On the left side of the picture, you can see a normal ultrasound of a preterm neonate, and on the right side of the picture, you can see a grade 3 intraventricular hemorrhage with an enlarged ventricles filled with blood. Our clinical question focuses on the time distribution of onsets of intraventricular hemorrhage in preterm neonates under the gestation age of 32 weeks during the first week of life. Our clinical implication is to assess the onset of intraventricular hemorrhage and preterm neonates and optimize population, screening frequency, and design a clinical trial. We hypothesize that there is a typical time distribution pattern of intraventricular hemorrhage. We conducted a systematic search in 4 databases, with the search key consisting of the following domain: age, the disease in question, which is intraventricular hemorrhage, and the screening domain. After a thorough analysis of literature, we will focus on the onset of intraventricular hemorrhage in preterm neonates. We will write a clinical trial protocol of IVH screening just to gain a deeper understanding of the onset of intraventricular hemorrhage, and then we conduct an international clinical trial with the Netherlands. As I mentioned before, IVH is a frequent complication of prematurity. There are several antenatal, antepartum, and postnatal risk factors known to increase the incidence of intraventricular hemorrhage. But however, their time-specific effects are poorly described. Our candidate risk factor will be neonatal low systematic blood flow at birth and the lack of antenatal steroid prophylaxis. Our aim is to describe the distribution of onsets of intraventricular hemorrhage and identify time-specific factors in neonate born equal or under the gestational age of 28 weeks. Our clinical question will focuses on time distribution of onset and risk factors of intraventricular hemorrhage in preterm neonates under the gestational age of 28 weeks. We are planning to perform a repeated cranial ultrasound to be able to detect intraventricular hemorrhage. Our primary outcome is our occurrence rate and onset of time of intraventricular hemorrhage, and our primary and secondary outcomes are time-specific risk factors. Our clinical implication is to assess the onset of intraventricular hemorrhage in preterm neonates, subsequently apply preventive measures, and implement interventions, for example, physiological-based cord clamping approach at the delivery room stabilization of a preterm neonates. We know that the delayed cord clamping decreases the incidence of intraventricular hemorrhage, and we think that physiological-based cord clamping approach at the delivery room stabilization of a preterm neonates will further decrease the incidence of intraventricular hemorrhage. We hypothesize that there is a time distribution pattern of onset of intraventricular hemorrhage. With our collaborators, we already agreed on to include inborn preterm neonates under the gestation age of 28 weeks with the presence of a parental consent. We plan to exclude outborn preterm babies beyond the gestation age of 28 weeks and preterm infants with brain malformation diagnosed early in utero. As you can see on the picture, we are planning to perform a repeated cranial ultrasound, especially within the first 24 hours of life. I plan to submit my first project in May, and I plan to submit my second project in the beginning of 2024. I would like to share a quote with you. It's from Erasmus Darwin. He wrote it down in 1801. He already knew when you have to clamp the cord, and we forgot it for a couple of decades. Another thing very injurious to the child is the tying and cutting of the navel string too soon, which should always be left till the child has not only repeatedly breathed, but till all pulsation in the cord ceases, as otherwise the child is much weaker than it ought to be. Thank you for your attention.
Congratulations for this well-prepared presentation. And as a pediatric resident, I'm curious about the risk factors that can increase the incidence of IVH. Can you highlight some of them, please?
Yeah, unfortunately there are a lot. For example, chorioamnionitis, hypothermia, that lack of steroid prophylaxis, what I just mentioned. There are several maternal factors as well, like eclampsia or hypertension. And of course, postnatal risk factors like sepsis, like needing intubation or RDS, and so on.
Thank you. Well, thank you for your presentation. And I was wondering, you mentioned the physiological cord clamping that could be even better than delayed cord clamping, and what does this exactly mean?
It's a quite question. Basically, the first definition would be what I could tell you is that when the baby births and start to breathe, aerate his lungs, and then you clamp the cord. But you can say that you should clamp the cord when the pulsation ceases of the cord, or even when it seems to be really fat. It's still a question. But if you have a question about when should we clamp the cord, if it's a baby, a 24-week of preterm baby, I would suggest that it can be 6 or 8 minutes when you can really aerate the lungs, stabilize the baby, but of course you have to use a device like a LifeStat, as Greta mentioned. Thank you for your question.
Yeah, thank you.
Zsuzsa, you mentioned in the protocol that several intracranial ultrasonography needs to be performed. And now I mean, you working in the minimal handling area, and how can you balance between the benefits resulted from the minimal handling and those benefits will come from the multiple sampling or the multiple imaging performed during this study?
Yes, that's a really good question. That's what I asked from my supervisor when he approached me to this with this idea. And what about the minimal handling? And then we found out you shouldn't do a proper ultrasound. You have to do a really quick ultrasound, and it's so beneficial because this information is still lacking. We don't know when exactly the IVH is coming, and if you know that on admission that the baby still already got the IVH, it's something you have to do with the antenatal period, something what you can do with the woman.